Welcome to the Deep Dive. We sift through all the noise to bring you the core knowledge you really need, fast. Think of us as your shortcut to being seriously informed.
Exactly.
Today we're tackling a condition called homocystinuria. It's rare, yes, but fascinating. We'll pull out the essentials for you.
Yeah, we're using a comprehensive review on homocystinuria as our guide today, the mission, to give you a really clear, high-yield understanding. Perfect if you're revising or honestly just want to get up to speed.
Right. Because these inherited metabolic disorders, they can sound pretty daunting.
They absolutely can, but the goal here is to break it down, make it understandable, memorable, hopefully.
Okay, let's dive in then, starting with the basics.
Right.
What exactly is homocystinuria?
Well, in simple terms, homocystinuria is a rare inherited metabolic disorder. The main problem, usually, is a deficiency in an enzyme called cystathionine beta-synthase, CBS for short.
CBS, like a key worker in the body.
That's a great way to put it, yeah. And when CBS isn't doing its job properly, you get a buildup of an amino acid called homocysteine. It builds up in the blood and also in the urine. And what's really striking, is that babies born with this, they can seem completely fine initially.
Really? No signs at birth?
Often. No obvious signs. But if it's not picked up and treated early, quite severe complications can develop during childhood, which really underlines why newborn screening is so important for conditions like this.
Makes sense.
And while that CBS deficiency is the most common culprit, it's worth knowing there are other, less common types. Sometimes it's related to other enzymes in the same pathway, like MTHFR, or issues with how the body uses vitamin B12, which is also called cobalamin.
So CBS is usually number one, but there are other possibilities.
Exactly. CBS is the main focus, but the broader metabolic picture can sometimes involve these other factors too.
Okay, so this CBS deficiency seems key. What's the actual cause, the etiology?
Right. The etiology is primarily genetic. It comes down to mutations, changes in the genes that tell our body how to process another amino acid called methionine.
Methionine, okay.
And the CBS gene itself is the major player here. If you want the specifics, the CBS gene is located on chromosome 21. The exact spot is gene locus 21q22.
Wow, specific address.
Yeah, exactly. And like we mentioned, less commonly you might see problems with other enzymes or even the cofactors. Those are like helper molecules that enzymes need to work. If those aren't right, it can also lead to homocystinuria.
Got it. And who's most likely to get this? Are there particular risk factors?
Well, because it's inherited, the main risk factor is simply having parents who carry the faulty gene or genes.
So it runs in families.
Yes, exactly. It's an autosomal recessive condition.
Autosomal recessive. Remind me what that means.
Sure. It means that for a child to actually have the condition, they usually need to inherit 2 copies of the non-working gene, one from their mother and one from their father.
Okay. Both parents have to pass it on.
Typically, yes. If both parents are carriers, meaning they each have one faulty copy but don't have the condition themselves, there's a 1 in 4 or 25% chance with each pregnancy that the child will inherit both faulty copies and develop homocystinuria.
Okay, that's clear. So the CBS enzyme isn't working right. Homocysteine builds up. What actually happens inside the body then? What's the pathophysiology?
Right, this is where we see the effects. The reduced CBS activity messes up a really crucial step in metabolism. It stops the efficient conversion of methionine into another amino acid, cysteine.
So methionine doesn't become cysteine properly.
Exactly. And as a result, you get this backlog. Both homocysteine and methionine start to accumulate in the body. And this buildup isn't harmless. It can actually damage various organs and tissues over time.
How does it cause damage?
Well, one interesting mechanism involves collagen. Collagen is, that really important protein providing structure everywhere, skin, bones, blood vessels.
The body's scaffolding.
Precisely. High levels of homocysteine interfere with the way collagen fibers normally link together, sort of like the crossbeams in that scaffolding.
So it weakens the structure.
Yes, exactly. This disruption in collagen integrity is thought to contribute to quite a few of the physical problems we see, especially the skeletal issues and problems with blood vessels in the eyes.
That really helps connect the dots. Now, if a doctor is seeing a patient and suspects homocystinuria, what else might be on their mind? What's the differential diagnosis?
Good question. The #1 condition that often gets considered alongside homocystinuria is Marfan syndrome.
Marfan's. Right, because they share some physical features.
They do share some similarities like tall stature and long limbs sometimes, but there are really crucial differences that help distinguish them.
Okay, let's nail those differences down. What should we look for?
Okay, first off, inheritance pattern. We just said homocystinuria is autosomal recessive, needing 2 gene copies. Marfan syndrome, that's autosomal dominant. You only need 1 copy of the mutated gene to have it.
Big difference. Okay. What else?
Heart involvement. It's relatively rare to have major heart issues in homocystinuria itself. But in Marfan's, heart problems are quite characteristic, especially things like aortic incompetence, where the main artery's valve doesn't close properly.
Right. And the eyes. I remember something about the eyes.
Yes, the eyes are a key differentiator. In homocystinuria, if the lens of the eye dislocates, which is common, it typically shifts downwards.
Downwards.
Whereas in Marfan syndrome, the lens dislocation is usually upwards.
Upwards in Marfan's, downwards in homocystinuria. Got it.
Then there's cognitive ability. Learning disabilities are unfortunately quite common in homocystinuria. That's not usually a feature of Marfan syndrome. Intelligence is typically normal.
Okay.
And finally, skeletal features, again, both can have that tall Marfanoid look. But homocystinuria carries a specific risk of recurrent blood clots, thrombosis, and also osteoporosis, weak bones.
And Marfan's?
Marfan's is more typically associated with things like scoliosis, which is curvature of the spine, flat feet, and hernias. So distinct patterns there too.
That's a really useful comparison. Are there any other, maybe less common things that could look similar?
Yeah, it's worth knowing that other things can cause elevated levels of cysteine in the urine, which might be an initial clue. This can happen sometimes in elderly people or postmenopausal women.
Just normal changes.
Sometimes, yeah. Or certain conditions like kidney failure, hypothyroidism, that's an underactive thyroid, even leukemia or psoriasis. And some drugs can do it too, like methotrexate or isoniazid.
So high cysteine in urine isn't automatically homocystinuria.
Exactly. It's a piece of the puzzle,
Sure.
but definitely not the whole picture on its own.
Okay, let's shift gears slightly. How common is this condition? What's the epidemiology, say, here in the UK?
Right. In the UK, the prevalence is estimated at around 1 in every 344,000 live births. So quite rare.
1 in 344,000. Okay.
Interestingly, it's actually more common in Ireland. There, the rate is about 1 in 65,000 births.
Wow. Significantly higher. Any reason for that?
It seems related to a specific genetic mutation known as G307S, which is more frequent in people of Celtic origin.
Ah.
And just to reiterate, the inheritance pattern is that autosomal recessive one we talked about. But a really important point in epidemiology and treatment is that about half, maybe 50%, of people with homocystinuria respond well to treatment with pyridoxine.
Pyridoxine, that's vitamin B6, right?
Exactly, vitamin B6. And those who respond to B6 often tend to have a milder form of the disease overall.
That's good to know. So, moving on to how it actually looks in a patient. What are the typical signs and symptoms? The clinical presentation?
Well, it can vary quite a bit between individuals, but there are common themes. You might see delays in development, intellectual disabilities, skeletal problems like being unusually tall or having scoliosis.
We mentioned the skeletal links.
Yes. Also, eye problems are very common, that lens dislocation we talked about, or severe nearsightedness, myopia, and critically, there's an increased risk of blood clots.
Blood clots. Okay.
Yeah.
You mentioned some key features earlier. Is there a way to remember the really classic signs?
Yes. Mnemonics can be helpful here. How about this one? Fair Marfanoid osteoporosis, learning seizures, downward thrombosis.
Okay, say that again.
F for fine, fair hair. M for Marfanoid body habitus, that tall build, long fingers, arachnodactyly. O for osteoporosis, L for learning difficulties, S for seizures, D for downward lens dislocation, and T for increased risk of thromboembolism, those blood clots.
FMOLSDT? Fair Marfanoid osteoporosis, learning seizures, downward thrombosis. That's actually quite catchy.
Hopefully memorable.
Yeah.
And in terms of what doctors find, well, elevated levels of homocysteine and methionine in the blood plasma are key biochemical markers.
Right, the blood tests.
Exactly. And those ocular abnormalities, especially the lens dislocation, they're found in about 80% of homozygous patients, people with 2 copies of the faulty gene. Usually these eye issues become apparent by age 3 or 4.
So they develop over the first few years.
They often do. And we could sort of categorize the presentation by body system too. Skeletally, that Marfanoid look, fine brittle hair, maybe a high-arched palate, joint issues, eyes, lens dislocation, myopia, glaucoma, and CNS central nervous system, learning disabilities, seizures, maybe strokes, even psychiatric disorders sometimes.
It really does affect multiple systems. So if the signs and symptoms point towards homocystinuria, what investigations are typically done to confirm it?
It requires a pretty thorough workup. First, Those blood and urine tests are vital to measure homocysteine and methionine levels. That's usually the starting point.
Blood and urine. Okay.
Then, genetic testing is really important to identify the specific mutations in the relevant genes, like the CBS gene.
Find the exact genetic cause.
Precisely. Imaging studies might sometimes be used, maybe to look at blood vessels or bone density, though they aren't primary diagnostic tools usually. There's also a specific urine test, the cyanide nitroprusside test, which looks for certain sulfur compounds.
Cyanide nitroprusside, okay.
And of course, a detailed eye exam by an ophthalmologist is crucial to check for myopia and that characteristic lens dislocation.
Makes sense, given the eye involvement.
Then, to directly measure the enzyme's function, you can actually test the CBS enzyme activity in tissue samples, usually from a liver biopsy or sometimes a skin biopsy.
Oh, biopsy,
Yeah.
wow.
Yeah, gives a direct measure. And finally, to check for osteoporosis, X-rays and especially DEXA bone density scans are used.
That's quite a list. Blood, genes, urine, eyes, tissue, bones. Is there a quick way to remember those main categories?
That's pretty much it. Think blood, genes, pee, eyes, tissue, bones. That covers the main areas you'd investigate.
Blood, genes, pee, eyes, tissue, bones. Good tip. So once it's confirmed, how is homocystinuria managed, particularly here in the UK?
Management really hinges on early treatment. The sooner you start, the better the chances of preventing or minimizing those long-term complications.
Okay. And the main treatment is?
The primary medical treatment is often pyridoxine, that's vitamin B6 we mentioned earlier. But it depends.
Depends on what?
On whether the patient responds to pyridoxine or not. About half do. For those who are pyridoxine sensitive, the treatment usually involves high doses of B6, often along with folic acid and vitamin B12 supplements. The goal is to help lower those homocysteine levels.
And for the other half? The ones who don't respond to B6?
For the pyridoxine-insensitive patients, the main strategy is different. It involves a strict, low methionine diet.
Low methionine, that amino acid that builds up.
Exactly. You restrict the dietary intake. This is often combined with a supplement called betaine, which provides an alternative pathway to help process homocysteine and lower its levels.
Why is that diet so important for them?
That methionine restriction can make a huge difference. It's particularly effective in helping prevent or reduce the severity of learning disabilities, and it also lowers the risk of lens dislocation and seizures. It's a very specialized diet, though. It needs careful monitoring.
I imagine so.
Yeah, and it's crucial to make sure these patients don't become deficient in folate, as they can cause other problems. Doctors will also keep an eye on cardiovascular risk and might consider preventative measures like low-dose aspirin or statins for some individuals.
And given all the systems involved.
Referrals are key. Regular checks with ophthalmologists for the eyes, neurologists potentially, maybe psychiatrists if needed. It really requires a multidisciplinary team approach.
Okay, so just to circle back on that point for clarity. If a child is suspected to have homocystinuria, they try vitamin B6 first. But if there's no improvement?
Then the next likely step, yes, would be to start that specialized low methionine diet and introduce betaine supplementation.
Got it. What about the long term? What's the prognosis generally like for someone with homocystinuria?
Well, the outlook has really improved dramatically, mainly thanks to newborn screening, allowing for much earlier diagnosis, and of course, these effective treatment strategies we've discussed.
So early treatment makes a big difference.
A huge difference. Starting treatment early can often halt the progression of many complications, and in some cases can even reverse some of the existing issues.
That's really positive. Finally, what are the major complications we're trying to avoid? What happens if it's not managed well?
Yeah. Unfortunately, untreated or poorly managed homocystinuria can lead to some pretty serious problems. Maybe another mnemonic could help here. Think thrombosis in heart, then bones in liver and pancreas.
Okay, thrombosis in heart.
So thrombosis, that high risk of blood clots forming in veins or arteries, which can be life-threatening. Heart problems, things like coronary artery disease, heart attacks, even mitral valve prolapse.
And bones in liver and pancreas?
Right. Bones, that early onset osteoporosis we mentioned, leading to fragile bones, often affecting kids by their teens. Liver issues like fatty infiltration. And inflammation of the pancreas, which is pancreatitis.
So quite a range of serious potential issues.
Definitely. It highlights why the management is so critical.
Okay, so summing up then. Homocystinuria. It's a rare inherited metabolic disorder, primarily affecting the CBS enzyme, leading to homocysteine buildup. Key features can be remembered with FMLSDT. Diagnosis involves blood, genes, pee, eyes, tissue, and bones.
You got it.
And management depends on vitamin B6 response, using either B6 supplements or a low methionine diet with betaine. Early detection and treatment are absolutely crucial to prevent serious complications like thrombosis, heart issues, and osteoporosis.
Precisely. And, considering how varied the symptoms can be, eyes, bones, brain, blood vessels, it does make you pause and think, doesn't it? What other, maybe seemingly unrelated symptoms might actually warrant considering an underlying metabolic disorder?
That's a really interesting thought, how these complex biochemical pathways can have such wide-ranging effects.
Exactly. Just shows how interconnected everything is at that fundamental level.
Absolutely. A great point to end on. If you, the listener, want to dive deeper into topics like this for your MSRA revision, definitely check out passmsra.com and also our free resources at freemsra.com.
Great resources there.
Thanks so much for diving deep into homocystinuria with us today.